AM Impact on Your Health is sponsored by Dennis J. Courtney, M.D., Director of the Courtney Medical Group, located at 3075 Washington Road in McMurray, Pennsylvania. For more information or to make an appointment, call 724-942-3002. That's 724-942-3002 for Dennis J. Courtney, M.D.
Good morning, everybody. Good morning, everybody, and welcome to AM Impact on Your Health. AM Impact on Your Health, where every day our goal is to have you learn at least one thing to help you live better and longer. AM Impact on Your Health, well, it's heard each and every Monday, Wednesday, and Friday from 8 to 9 o'clock. I'm Dr. Dennis Courtney, and I'm with you each and every Monday, Wednesday, and Friday from 8 to 9. AM Impact on Your Health, where each day you'll find current medical news, knowledgeable guests, fascinating health topics, and where we do encourage you to call in to join in. Today is a Friday version of the show. Get 'em up, out of town version as that is. Understanding the weather is to break slightly in the positive here as the weekend unfolds. We have a little bit out of character for a Friday for us in that we have a guest today. It's going to be a piggyback, sort of a 1-2 punch, we hope, to try to bring you up to date in your knowledge base about how to correct pain problems that you may have personally, or that others whom you know or whom you are related to may have, and seem to get little to no relief, especially not even finding out the cause of what may be provoking that pain. All under the guise of a new way I brought to you the other day of looking at this subject. We are in an electronic age. We have all sorts of electronic wizardry, and a device I've been using for years entitled the Matrix is something that I believe you should have in your armamentarium, in your vocabulary, to know that if you ever should have a pain problem, there'd be a way to absolutely get tremendous amounts of relief through a process called electroanalgesia. Now, we spent some time the other day with two gentlemen, one a manufacturer of the product himself, Peter Beltram, another one a clinician who's been working with this device for a number of years, named Mike Gramazio. Today we'll call it part 2. We're going to visit a colleague, to the extent another anesthesiologist that I just met recently, who's over here in Akron, Ohio, and also utilizes this device. We need to compare some notes, allowing you to hear my take and his take on how all this has worked in the clinical environment that he and I both work in. So it's more about electroanalgesia today. Just put it in the back of your mind. If you have no pain problem, put it in the back of your mind for now. Unfortunately, maybe the day may come where you do. Certainly you're going to come across people all the time that have these pain issues and just can't get rid of. Whether that's acute pain from a fall you had yesterday, or whether it is a complete mystery to you and your doctors as to why you have pain, which may have been initiated years ago, 5, 10, 15 years, and you're still in pain. Hey, there's still a way to get out of it using electroanalgesia. We'll be talking about today with our guest, Dr. Frank Kousaie. Now, if in the course of our discussion with Dr. Kousaie, you want to call in to ask a question or to make a comment, that number, of course, as always, will be 412-825-6262. That's 412-825-6262. More on this subject of electroanalgesia today. Now, looking at the calendar, the rest of October is just jam-packed. It's been jam-packed since the beginning, right out of the chute. On Monday, we're going to have Bill Henderson with us. Now, I sometimes just turn on my little radio here in the office, and yesterday afternoon, I think it was around 2 o'clock, 1 o'clock, Bill Henderson, I caught a piece of his interview on a local, right off of this station, KHB station. I don't know who the interviewer was, I'm sorry, but I was fascinated by what little I was able to gather yesterday. I'm really looking forward to having Bill Henderson with me on Monday. He, of course, is the featured speaker at the Freedom of Choice in Cancer Therapy Group, which will be holding their monthly conference this month on, here it is, it's actually the third Thursday, as they normally like to keep it, 7 p.m. Days Inn, Route 8 in Butler. And in keeping with sort of the tradition around here, whenever their speaker comes to town, within that week, we try to get him on the airways. And sure enough, he's going to be on our airways on Monday. He was on another interviewer schedule on yesterday. And so I really think I could gather from him very knowledgeable, written 3 books on, of all things, cancer therapies. Alternative cancer therapies, pretty tragic origination. I'll let him explain how he came to be involved so passionately with this kind of work. Written 3 books, as I say, his most recent one called Cancer Free, Your Guide to Gentle, Non-Toxic Healing. More from him, Bill Henderson, on Monday, and then get prepared to go on up and take a visit and see him in person on Thursday. Then the following week, when we come to round out the month, 2 really enjoyable guests we've had before. One extremely enjoyable, just here last month in Pittsburgh, talking about Cass Ingram coming to our airways in a rather stealthy way. I don't know how it's going to turn out. I know he'll be there with us because he's in England, and he's going to have to call us, and it's going to be, I'm guessing, about 2 o'clock in the afternoon over there. He should be, well, he's always bright-eyed and bushy-tailed, and listening to some of the comments from you who went to see him last month, the man is boundless with energy. So he's going to be with us on Monday talking about cures in the forest from which he just emerged. Now he's over in England, and I'll get him to talk about some blood pressure items and some other things. I just have finally got a full list of all his books. It's just his body of knowledge and the works he's put out over these many years are just valuable assets to all of you who are looking for a non-pharmaceutical way of conquering problems that you confront on a daily basis. Then on the 27th, he's coming back. He is the initiator and inventor of a product for, well, when things get cloudy upstairs, by the way, he says, are you suffering from, this is going to be the byline for our discussion on the 27th, are you suffering from CRS? Well, I didn't know what CRS was until I read on further. It stands for Can't Remember Stuff. Are you having trouble remembering stuff? Are memory issues starting to plague you? If so, you'll want to come back again and listen to Mark Underwood, who will be our speaker, our featured guest, on the 27th of the month as we move into that last week of October. Now, a couple things in the news. This month of October, as you well know by now, usually gets my goat going. When it comes to the National Breast Cancer Awareness Month, that doesn't get me going. It's just stealthily hidden, especially this year, is the intention that all women go get mammograms. Now, that's the part that bothers me. I'm hoping that thermograms are going to be the new thing on your agenda this year, ladies. But this morning, in one way, I was excited and then let down because there I was watching Fox and Friends, and the blurb came about how the NFL is getting upset and is not happy with National Breast Cancer Awareness Month. And I said, oh my God, did somebody finally get them the information? Did somebody finally tell them the truth about these mammograms? And they're finally going to take a stand? And so with anticipation, I waited until they got to that segment, and boy, was I let down. Turns out they're upset, all right. Some people were talking in circles in the NFL that this is a problem for the NFL, talking about National Breast Cancer Awareness Month. Why is it a problem? Well, it really has nothing to do about the trials and tribulations of mammography. It has to do with what they say is they're putting that pink stuff on the football, and with those new gloves with the pink, the ball's too slippery, and it's causing us a problem with throwing this ball. And so we're really upset with the National Breast Cancer Awareness Campaign because we're not able to handle that ball as well as we could before they put that pink slippy stuff on there. Well, as you can see, my anticipation, I should have understood it, was really trounced by hearing what was really on the minds of the NFL. So I thought I'd pass it on to you. So hey, just get those thermograms, please. Ladies, give us a call here at the office at 724-942-3002. If you're interested in coming to our office, they mean the technicians come to do thermograms twice a month. They travel a whole bunch of places in Pittsburgh too, so if you think you'd like to find someone closer, I'll give you that number right now that you can call and talk to Judy and Sue to find out where they may be near you. And I know this signal travels far, so you may be really far south of us and far north, and they do come around, and they'll let you know when. But the number for them at their office is 412-548-3612. Once again, 412-548-3612. That just about rounds all that out. I thought that our discussion with the manufacturer of, and this is what I think maybe the take-home message from our Wednesday show is, or at least things that I've picked up. I've always come to really appreciate the potential of the use of this device I've referred to as a matrix. And I didn't know it to be difficult to find. I didn't realize it is so rare to find in this area, and happy to hear that that we're certainly well known throughout the country as being one of those centers that offer this device. So don't look, or be on the lookout for, maybe is a better way to say it, be on the lookout for those devices that are purporting and pretending to be electroanalgesic delivering. In fact, there is no device to the equal of this matrix. So you look at the machine, it has to say Neuromed on it, or matrix, or both. And if it doesn't, it does not have the capability of producing similar results. So today we are going to be, what else did I learn from them? 85%. I want to find out how the doctor in Akron is matching up to this. They say 85%, upwards of 85%, can expect to get significant pain relief, and usually takes about 4 to 6 treatments. I knew it didn't. I told patients that don't ever walk away from this device after a first encounter that didn't produce the kind of results that you were looking for. It turns out the number 4 to 6 treatments is probably what's needed to get you up to speed there, and then the resolution of the pain issue is what I was really interested in, and it could actually be up to complete pain relief for a sustained periods of time with the use of this device we refer to as either Neuromed or Matrix. Look for it on the label of that machine. Don't settle for any who are not presenting you with that kind of device. All right, so let's do this. In keeping, we're going to call it part 2 with our subject that we're going to round out today on this Friday version of the show. We're going to get together with an anesthesiologist, a very accomplished one in the city of Akron, Ohio, over the line here, who utilizes the matrix every day. He says, let's compare some notes. I'd like to compare mine with him. You will be the benefactor of those note comparisons, and hopefully you'll be able to walk away really rounding out your education this week on electroanalgesia. We continue with Dr. Kousaie when we return.
This is Dennis J. Courtney, MD. You become confused about how best to manage your health. It's no wonder. It seems that every time you turn on the television or radio, another expert has yet another suggestion for you to follow that seems to be reasonable enough, but no matter how dutifully you follow the instruction, it just doesn't quite produce the results that you were looking for. If this confusion sounds familiar to you, give us a call at the Center for Complementary Health, where we'll make some sense of the confusion based on a blending of traditional and alternative medicine that we've been perfecting over the last 7 years. We offer metabolic nutrition testing, immune system repair, natural hormone replacement therapy, elation therapy, cutting-edge allergy correction, and a host of other safe and effective alternative therapies.
Dennis J. Courtney, MD, is located at 3075 Washington Road in McMurray. Phone 724-942-3002.
Want to help your family eat healthier? Instead of learning to disguise tofu with Wondrous Way, how about some real nutritional power? If your family has the typical American palate for fries, pizza, and burgers, giving your family the blessing of good nutrition is a struggle. Fruit of the Spirit is the answer for your family's nutritional needs. Fruit of the Spirit is an all-natural, whole fruit puree made from fresh fruits native to the Holy Land with alkalizing minerals. Fruit of the Spirit was 5 years in the formulation, the work of a team of top nutritional experts with independent science to confirm its antioxidant power. 1 ounce a day provides the equivalent of 5 servings of fruits and minerals. Fruit of the Spirit is convenient, affordable, and delicious. Even your picky family will sing the praises of Fruit of the Spirit. Give your loved ones the blessing of good nutrition. Call 1-800-442-3793 for a special promotional offer. Fruit of the Spirit, a blessing for your good health. That's 1-800-442-3793. Call them now, 1-800-442-3793.
Hey, good morning, ladies and gentlemen. Welcome back once again to AM Impact on Your Health, heard here on KHB 620 each and every Monday, Wednesday, and Friday from 8 to 9 o'clock. I'm Dr. Dennis Courtney with you on this Friday version show, usually a get 'em up out of town version where we just open it up to you. Today, a little out of character for that, but a continuation of what we started just the other day when we brought to you a concept of maybe how to take care of pain problems that you may have. Some very fresh, maybe occurring in the last week or so, others really long-lasting, and the frustration that comes along with it is one that my guest today can share with me. I'll consider him a colleague of mine. You see, we're both anesthesiologists. I rarely get a chance to talk to a colleague utilizing this device specifically. We're taking ourselves out to Akron, Ohio, not too far away, with a gentleman who practices the art of how to treat pain every single day. He does so in a couple different ways. We're going to let him explain that to you and let you take some more notes on this device called Matrix, called Neuromed, utilizing something called Electroanalgesia. His name is Dr. Frank Kousaie. He's with us right now. Let's say good morning and welcome aboard, Frank. Thanks for coming aboard with us this morning.
Dennis, thanks for having me.
I really enjoy the opportunity to put a part 2 onto what we started just the other day. Now, you knew the players. I talked to you on the phone just a bit the other day, and certainly know Peter Beltram, the manufacturer. You were very much aware of Mike Gramazio, quite a clinician in his own right, utilizing this device. And so, in keeping with the theme of electroanalgesia, and now having the opportunity to have a discussion with a colleague of mine who uses a device, treats pain every day, I thought this is the perfect conclusion to round out this topic. I'd like to start by letting you, and really be a nail biter for me just to listen to your CV in a way and how it is that you moved into medicine. Folks, we are talking to a medical doctor here who's got, a background of education that really equals what is needed to be able to provide these kinds of services. Frank, take it away for a bit. Talk to us about you, how you came to come into medicine, why you chose anesthesia. I got my own story, but what you're doing right now, too.
Well, thank you. I was born and raised right here locally, actually in Kent, Ohio, the home of Kent State University.
Oh, yeah.
I attended Miami University of State School in Oxford, Ohio, and then went to Omaha, Nebraska, and graduated from Creighton University School of Medicine, only one of 4 Jesuit schools of higher learning in the country. Got my MD, and while I was there, I felt that anesthesia was the last bastion of pure family medicine, and I jumped at the opportunity. I mean, you deliver babies, the orthopedics, neuro, do cardiology. It was the last bastion of all-around medicine.
Oh, you're sort of involved with everything, kind of, so to speak, huh?
Right. I mean, you do pediatric cases, OB, neuro, cardio, orthopedics, and
interesting perspective. But I have to agree with you. Certainly, you are involved with every aspect of every specialty that's out there, from a viewpoint of getting them to a anesthesia level that allows them to perform the procedures that they want to perform. So yeah, I got you. Very good. So you decided to go into anesthesia, huh?
Yeah, that was really what I wanted to do. And then when I got in it, I realized that what I really enjoyed was the pain relief aspect of it. And I started to specialize in regional anesthetics.
What are, for our listeners, so that they can appreciate that, when you and I use the term regional anesthesia, what's meant by that term?
Well, what you're doing is you're providing a conduction block so that the pain that you would have felt from a incision, from surgery, is actually blocked at a nerve level. It stops. It doesn't go to the brain. And you do that by interrupting basically the nerves with chemicals, lidocaine, novocaine, everybody's heard of novocaine, at an area remote from where they're working. So if they're working on the hand, you may stick a needle in an armpit and drop the medicine in there, or stick it in the neck, and that would block it. Spinals are another way to do a quote, regional anesthetic. But more specialty to what I would do is, instead of doing the spinal, I'd stick it in the sciatic and femoral nerve.
Now, I'm sure our listeners are wincing when you use the word stick it, okay? But I got to tell you, folks,
Place it.
yeah, place it, okay. I know that industry-wide, one profession to another, certainly I don't wince from it, but nonetheless, I got to tell you that as I view the use of regional anesthesia, and by the way, you use your regional anesthesia every day in an operating room environment because you literally work within the confines of an outpatient surgery center, right?
Yes, here at Crystal Clinic in Akron, Ohio.
At that Crystal Clinic, and I was sort of there at the advent when surgery centers just came to the forefront, just became like hot things to have. And I'll tell you that the anesthesia as a profession wasn't really ready for the burgeoning of the concept, because all they were doing was mini general anesthetics, and so they used every single drug that they would have used if they were talking about a patient who was going to be staying overnight or maybe days in a hospital, and they just used every drug, but they used a little less of it, thinking that, well, it's a mini procedure, they're going home. And as it turned out, there were so many problems that came from it because of nausea. People didn't go home. That was the problem. Did you ever did you see or observe anything like that in your experience? Because I certainly did in mine.
Oh, absolutely. In fact, years ago, I had gotten out in 1989, and a bunch, 14 surgeons and myself started a surgery center in Kent, Ohio. And we covered every specialty. OB, we had general surgeons, we had plastics, we had orthopedic. And the problem was anesthesia wasn't ready. So with the advent then of my love for regional, we actually were doing laparoscopic cholecystectomies on an outpatient basis. And you know, because you've done, that used to be a 3-day stay in the hospital.
Yeah. Now you're telling me you use a regional block for...
We used to do intercostal nerve block. And then, with the advent of paraspinal, not actually on it, but paravertebral block, made it even better.
Wow. I actually, to be honest with you, this is the first time I've ever heard of doing regional anesthesia for gallbladder surgery.
Oh, it was still under a general.
Oh, still under... Okay.
A lot of the pain relief was...
Okay, so that when they finally emerged from anesthesia, they were having pain relief that allowed them to go and go on home that day, as opposed to being confined to the hospital as one would expect to have post-operative surgery. Gotcha now.
Surgeons I worked with also would inject every one of the sites that they would use for their trocars. So you're doing preemptive analgesia, even though that guy's been proven wrong that he fudged the results on his little preemptive analgesia report when that came out, whatever it was, 10 years ago. It still does work. If you inject the trocar sites prior to have a little paravertebral block, intercostal block, you block a lot of that surface pain.
So today, is it that as you do your job every day within the confines of the surgery center, are you using regional blockade as an assist and still doing general anesthesia besides, or do you do just regional blockade, period?
Well, it depends on the patient. Most patients, as you said, that would be wincing when I said they're going to stick them.
Stick, I know, yeah, the bad.
You'll have to understand, most patients say, I don't want to hear, I don't want to see, I don't want to feel. So what we're doing is I will do a regional anesthesia on you, interscaling block, supraclavicular, femoral sciatic, and either a very light general anesthetic, one in which they can actually breathe. We call it masking them.
Okay.
Or even just using a little LMA. And sometimes they're just in what we used to call a mask. They're just heavily sedated. They're breathing on their own.
Yeah, an IV sedation, sort of
IV sedation.
the Versed propofol regime.
Yeah.
Okay.
Propofol and a tiny little bit of fentanyl. And wake up, your arm is numb. And, we do 90% of our surgeries that way.
All right, so surgical-wise, out there in Akron at the Crystal Clinic, you certainly are doing new age forms of anesthesia. I'm happy to hear that it seems like by combining the two, you get the best of all worlds. And so I like hearing the fact that the blending of the regional is, even from the surgeon's viewpoint, something he knows will make that a better experience for those patients. So by the way, the take home for those listening to us and sort of having the ability to get a behind-the-scenes look at between two anesthesiologists is if you need to have a surgery, folks, you need to be questioning your anesthesiologist much more than you already are, and you need to be finding out, is the goal to use a general anesthetic in combination with a regional block? And if you find that is being met, you're probably at the new age forms of surgery centers. But if you're finding that general anesthesia is only going to be used and no regional block, there's the ones that I would raise a red flag to. Wouldn't you, Frank?
I would.
Okay. Now we're going to move away from the anesthesia for surgery component and move into another one of your many loves, which is, and it happened to me too, as an anesthesiologist going in, working on putting people to sleep for surgery. I developed a real passion for working with pain problems, as you have. And then you have taken the level of using regional anesthesia to an art form, and it truly is a real art in anesthesia, in the anesthesia part. They can do a general anesthetic, but not too many can do regional blocks. So my hat off to you that you practice that form of anesthesia every day. Let's turn to the pain clinic. In your pain clinic, you see acutely injured, you see the chronically afflicted. Tell me how you manage your pain clinic, because I'd love to hear how things work out at the Crystal Clinic in that regard.
Well, very similar to yourself. The whole thing is you evaluate them first. That's the biggest thing that you and I would do as anesthesiologists. We are basically very good with coming in, listening to the patient's problem, and then deciding what our course of treatment can be. And of course, with the acutely injured, it may be sending them to another specialist saying, hey, this possibility could be a fracture. Let's get an X-ray. Let's send you to, this guy. I have a wealth of orthopedic specialists right here at the Crystal Clinic. And then, if all it is treatment, you got to decide how it is you want to treat. And early on, we had very few tools. Look, you watched pain management grow. We had very, very few tools. You gave trigger points, did an epidural, you gave pain meds. Now, look at the wealth, and the Matrix is just one of those machines that is just, we have a plethora of ways we can treat people. And what you can do is tailor-make the treatment for each individual patient. And the Matrix gives you the ability to treat a wide range of patients that you might not have been able to treat because of anticoagulation and other issues with a regional technique. Don't you find that to be true?
Well, yeah, absolutely. I guess I've been using the Matrix now, I'm going to say, about 8 years. How long have you been using it, Frank?
Probably about 6.
Okay. So it's pretty similar in terms of the length of time you and I both first come to be aware that there is a device out there that could do such a job. When I first was exposed to Matrix, I did so skeptically. I heard the instructor tell me how wonderful this thing could provide pain relief. Boy, it turned out he was really right. That's my first question: is were you surprised at how effective the matrix could be, even under crude hands when you were first learning to use the device? You were getting some pretty good relief because you had to. I was getting excellent results. Did you find the same thing to be true?
Oh, absolutely. It was like that whole deal. It was, like I said, I was still in the mode where, I was doing some regional, actually in the office, to help people, a lot of intercostal nerve blocks, tons of trigger points. The matrix came along, and I'm like, I'm getting as good, if not better, results with this without having to inject people, without having, there was just, and as I've refined it, I actually use it now with acupuncture. In fact,
okay.
All of my patients that use the matrix get an acupuncture treatment with it.
Well, I can see stealthily hidden in your answer is something I had to come to realize too, which is, yes, regional blockade nerve blocks, which is really the way that we were all trained, you and I both, trained to treat pain problems, was to go ahead, load up the syringe. You'll use the term stick it. I can appreciate that. That's a term that you and I can use, and the public winces a bit. But, to place the anesthetic in the right area to do a nerve block was the only way we were taught to handle these pain problems. There are risks associated with it. These are not risk-free. The better the hands, the less chance that things will happen. But when you start talking about directing a needle through tissue, applying chemicals to tissue, and having to do this at frequent intervals, this is not good for that tissue. It really isn't healthy for the tissue. And so I was so enchanted with the ability that I could avoid that and get as good, in some cases, if not better results than I would get with using nerve blocks that it didn't take long for me, and I like to find out how long it would take for you too, to reach a point where I said, hey, let's just do the matrix and not get involved with sticking that needle in there. You probably come up with the same kind of a formula in your own mind for your own practice?
Absolutely. It soon became apparent that it was both cost-effective and actually medically effective, and people wanted it. They came because they heard I had, at first, it was kind of funny, I just got to tell you, I had a few patients go, all he wants to do is put suction cups on. And it's been ballooned by word of mouth that you're just not a pin cushion, and that was the term a lot of people used. When you went to a pain clinic physician, you became a pin cushion. Because exactly what you said, we were trained to assess, see where the part that was, understand the anatomy of the nerves, placing then the medication near those nerves or into the affected muscle, and calling it a day, basically. Well, that's okay, now go and let the steroid, let the medicine work for a while. Now with the matrix, they're not only are we not doing that, they're walking out of the office immediately saying, I do feel better, and then getting better as they go along.
Now here's a real colleague-to-colleague query that I'm hoping that my listeners will enjoy, sort of seeing the curtain pulled back from the wizard, all right? Because I have a problem with what we were taught, and I'm interested in finding out whether you have seen and identified the same problem, because wherever we were presented with how to deal with a pain complaint, we were taught, load up the syringe, pick an anesthetic, mix some steroid in there, okay, and shoot. And literally, because of how well we could place that injection, the immediate response, that in 10 or 15 minutes response, usually was a very good experience for everybody. They did get pain relief. But of course, that was going to be short-lived. It may have lasted, depending on what anesthetic we selected, it may have lasted for an hour, it may have lasted for 3 hours, but it was going to wear off. And it was our intention, at least I interpreted my training as trying to teach me that it's the steroid that really we're hoping to quiet this tissue down, to cool it off. And so we didn't really know how effective we were going to be in terms of treating this problem until about a week to 2 weeks later, when we saw the patient again and literally sat in the background chewing our nails. We didn't know what that patient was going to say, because all we did was rely on that steroid. I found that it was something I couldn't rely on, that anybody's going to feel good with an amount of steroid involved, but injected. But in terms of correcting the problem, I didn't see where it was helping me too often. I want to know, did you come across a similar experience, or did you come up with better numbers than I did? Because I thought I was the worst anesthesiologist known to man for a while.
No, I was, you're exactly right. And the worst thing that happened would be I'd feel like a failure every time. You've heard of, the steroid flush. That is, the actual pain would get a little bit worse after the local wore off.
Yeah.
You get that steroid flush where they're like, wow, this really hurts. And I did. I felt like a failure. In fact, at one point, I almost stopped doing pain management just because of it.
Boy, you and I do match up point for point. I got so disgusted. Listeners, are you listening to me? If you're going to pain clinics right now, where all they're doing is blocks, and you get some immediate relief, but you get nothing sustained, you are in the same hamster wheel that Frank and I were in, realizing this is not where it's at. This isn't not how to do this job, yet it's still how it is taught across this country. With all the pain management training programs out there, the use of neuroblockade, I think, still goes on today as the main tool. Am I right about that, Frank?
Oh, absolutely.
All right, so you and I wised up a bit. We used what we were trained to use, and it wasn't working. And I had the same feelings of failure that you say you felt, and it made you turn to other things to utilize. Ultimately, the matrix is one of those things. And so now I ask you, looking at how your pain practice has evolved and the various diagnoses that are made, I think the matrix would be safe to say it doesn't matter what the diagnosis is. You should be able to get some substantial pain relief while whatever the other treatment that we're going to elaborate has a chance to work. That'd be the first thing I'd put to you. Is this the way you use your device? Because it certainly is the way I use mine.
Yes, absolutely. And the thing is, I've started to get, there's a lot of other pain clinics in the area, and these gentlemen, I know them well. I mean, with the tight community, they haven't come around to the matrix yet, but a lot of times they will send me their very, very recalcitrant patients, the ones that, they haven't been able to get any kind of pain relief. They've done epidurals, set joint injections, and they're just about to progress to a stimulator, which is a piece of equipment I'm glad people are starting to reach to. They're reaching for it a little more quickly, but they'll send their patients to me to have this modality done prior to that in an effort to maybe hold them off so they don't need that as quickly.
Now, ladies and gentlemen, the doctor mentioned the device. He used the term stimulator. Of course, doctor to doctor, that's all I had to say. My ears perk up because he's talking about something called a dorsal column stimulator, which it certainly emerged, I'm going to say, in the late 80s, early 90s. I think that's when I was trained to insert them. Nonetheless, it is a way of dealing with a pain problem when all else fails and you can't come up with a diagnosis in order to correct the problem. The dorsal column stimulator, which is placed just as the word says, in the dorsal column, it's done either percutaneously or surgically, is an now here's the key, an electronic way of getting complete or mostly complete analgesia from whatever pain problem may be, and yet not have to ever worry about the diagnosis. Was that the nutshell version of what a dorsal column stimulator is, Frank?
Oh, that's perfect. Yeah, absolutely.
Okay, so there are plenty out there now who move to the dorsal column stimulator when, in fact, if you had the matrix, you're still getting it is an electronically produced analgesia, but it's certainly not. You use the term suction cups, and that's interesting because with a few, 3 suction cups, 3 or 4, placed on the human anatomy for 20 minutes, the relief that you can get is just simply amazing. Talk to me about your experience with the matrix device in that respect.
Oh, well, one of the big things, obviously back pain is huge, and Akron's still an industrial area. I get a lot of back pain, and because I'm telling you, like I said, a lot of the docs now, they're not a surgical candidate, or they're post-laminectomy, the quote post-laminectomy syndrome, just before they move to the dorsal column stimulator, or God forbid, the indwelling intrathecal pain pump, which I don't even think we need to go into. They'll send them to me, and I do get wonderful results. I mean, you always know that there's a few people who will not respond to any treatment no matter how you do it. But literally, the people that said they were on the brink of, nothing has worked for them. They've had the injections, they've had the surgery, they've done the physical therapy, they've taken meds. We're getting absolutely fabulous results. I'm talking greater than 50% pain reduction for a long time. As long as, I mean, I'm talking 18 months. In fact, one lady just came back after 2 years because her pain went from a 0 up to maybe a 1 or 2, and she said, I've always heard there's a maximum number of treatments for most things. Can I have these again? I said, oh my God, there's no steroids, there's no injections. You can have more treatment. So she's very happy. She's having her back treated again. She didn't have to have her surgery, and she's very happy.
Hey, in the first part of your explanation, you mentioned something that just went right up my spine, where you had a patient have a surgery and not have relief from that surgery. Thereupon, before they were going to plan to do a dorsal column stimulator, they sent them to you.
Right.
And I can't tell you how many times, literally, Frank, in the recovery room, as a patient emerges from the anesthesia provided for his laminectomy, I could at that point know exactly whether this was a patient who was going to be okay and the surgery was correct and done correctly, or whether it was a surgical foray that was not necessary at all, or it had to be botched, because the patient who gets relief in the says, my God, my pain is gone. That's the guy I know that surgery was appropriately planned for. But the guy who says, oh no, I still have pain in my back and my legs and so forth, that was a guy who really, I would have said, and now say for sure, adamantly, should have never really had the surgery. I just want to compare some notes. Do you find that to be similarly happening to you with your patients?
Well, because I'm at an outpatient place, we do no backs. But when I used to be in the hospital practice, that was exactly it. You always had those people who woke up from a surgery, from a back surgery, that said, hey, my pain's still in my leg. I still have the leg pain, or I still have the back pain. Also, the other thing I see is a lot of times, every time you have a surgery, they make scar tissue. I mean, it just forms. You have to have scar tissue when you have an incision. So there's a lot of people that do well initially and form some scar tissue. And, we try to tweak those you try to tweak them. With the matrix, post-laminectomy, I'm getting very, very good results.
Yeah, that's, I hope, ladies and gentlemen, coming through. Post-surgical pain expected, correct, to be because of the incision. But it doesn't really matter what is provoking the pain. The message I'd like to get across to my listeners is, you have a way of dealing with pain and its magnitude in a very there's no risk associated with the matrix that I know about. No risk, yet what results are possible, whether or not you're really supposed to hurt because you fell down yesterday, or you were in an automobile accident last week, you had a surgery 2 months ago, or whether or not you have a chronic smoldering problem that lasts many years, you can still get similar results. You find that in your chronics too?
Oh, absolutely.
In the chronics.
Absolutely. Now, again, the proviso is you and I are doing a history of physical to find out where we believe the generation of their pain is. Sometimes that's impossible. And the nice thing about the matrix is it is a very comprehensive treatment. I mean, don't you believe so? I mean, you believe it's a very comprehensive.
Yeah. Well, we're searching to try to find out the answers, and sometimes the patient's so hot that it isn't even feasible in order to go look for some right now.
Exactly.
So I mean, if you get an acutely injured person, they need some time to cool off and let tissue heal.
That's the problem.
That's right. And in those cases, as well as the chronics, fresh injury or a long time ago injury, The matrix keeps coming through to me. Let's talk about some numbers that you usually. We had Peter and Mike Gramazio here on Wednesday. They're saying to me, because I asked them point blank, okay, what's the research show in the way of what's the percentage of patients that can expect to get substantial to fairly complete relief? And they said to me the number is around 85%. That's what their stats show. Now I'll tell you that I'm finding that 80 to 85% is a number I use, just never reading the research. It's just about the way it's turned out in my practice. I'm going to ask you, what kind of percentage can you expect of patients that used and received matrix treatments to respond?
Okay, good. Well, I would like to answer this twofold. First of all,
Good.
when I talk to patients, I always tell them, and I use the 1 out of 3 rule. I say 2 out of 3 people get pain relief. 1 out of 3 people doesn't. It's usually because I'm in the room with the husband and the wife, or the caregiver and the patient. So it's just easy to say, if I did it on all 3 of us, 1 out of 3 of us would not get the pain relief we desire. In the actual practice, I'm seeing greater than 85%.
You're seeing greater. So when you just said...
I'd say 89%. I mean...
Oh, that's great.
I'm close to... We're between 80 and 90% constant.
So when you said 1 out of 3, what you meant, I think I heard you said, 1 out of 3 of us isn't going to get the kind of pain relief that we wanted. Is that what I heard you say?
Correct.
That really almost all 3 out of 3 are going to get pain relief, but 2 out of 3 are going to get fantastic pain relief,
right,
and the third is going to get usually pain relief, just not to the level that they wanted upon their first exposure to the treatment. Is that a fair way to interpret what you just said?
That would be a very fair way to say it.
That is by the way, it's a great way of putting it. I may actually, you don't mind me stealing some of the colleague to colleague, ladies and gentlemen, this is what we do. But I think that's an excellent way of saying it. And let's talk about that, both categories. Let's talk about the 2 out of 3 that walk away literally with astounding relief. I want to ask you, for what length of time are they able to experience that kind of relief? Is it hours? Is it days for you? Does it turn out to be weeks? Because I know I've had patients of all 3 categories. What about yourself?
Well, and that's very interesting that you say that, because that's exactly what I see. When I have people who have more sedentary type jobs, been injured in car accidents, things like that, the pain relief is longer. There's no doubt about it. And they actually enjoy pain relief longer. When you have somebody that's out there changing truck tires, or, we still have Firestone and some other tire manufacturers here, and some steel, a little bit of steel. I mean, when these people are out busting, they're lifting, they're rolling 300-pound, 55-gallon drums around, I tell them, look, you're going to have to be a little more careful. They still get pain relief that they desire. They can go on for weeks.
Oh, that is great. By the way, I see isolated patients that can get weeks worth of relief. Others have set their schedule around. I got one guy I'm thinking in particular right now. Boy, he uses a cane. The man's so antalgically postured. You feel for the guy as you see him walk in your office, and instead of being home in agony, what has turned out for him to do, and he comes and tells me, look, this lasts fantastic for me for 3 days, and then my pain comes back. So we set up a schedule for him that he gets these matrix treatments every 3 days, and he is as happy as a bug in a rug. I mean, you couldn't find a happier patient. So 3 days for relief for him gives him a way to control his life when it was out of control. Now, I'd like to see him get more than 3 days, but I use it as an example because with that 3 days relief, which is very substantial, he lives his life, although he's afflicted, although he uses a cane, he actually is able to do things in his life that he can't ordinarily do until we brought in the matrix. Nothing ever worked in that respect. So 3 days, I would say, geez, I hate to hear it when someone only gets 3 days relief. But in his case, boy, am I happy the man gets 3 days relief. We do this twice a week on him, he's a happy camper.
Absolutely.
Do you find the similars?
Yes.
Okay. Let's talk about that third person, okay? Because this came up in a conversation. I'll give you a advanced glimpse as to what Peter and Mike said. Because I said, hey, look, what is this a immediate responder for most people? Well, they said no, and that sort of goes along with your 2 out of 3 thing. And then I said, well, look, how do the stats show that one should measure their decision as to whether they should continue the matrix or not? And what came out of their mouths was that they're both in agreement. You should at least do a minimum of 4 to 6 treatments before you make a call as to whether or not the matrix is going to be for you or not. I'm finding that to be true. I'm anxious to find out what you see.
And it's kind of interesting because I listened to your show the other day.
Oh, did you hear it?
Yes, I did.
Oh, okay.
And I went on the internet, which I found was very, very interesting. And I listened to Peter, and it's really weird because what we settled on in this clinic is 5 treatments.
Right in the middle.
Right in the middle. and honest to God, and my nurses, when we talk to the insurance companies, when we talk to workers' comp, we're going to do a minimum of 5 treatments, and then we're going to see. We do 5 treatments, and then we look at the patient. And then, we bring them back in and we say, okay, give us your pain scale. We don't just use an analog pain scale. We use ADLs, activities of daily living.
Okay.
What were you doing before? What can you do now? The only reason I go with this 1 out of 3 people is we will get pain relief in all 3 people. There are some people that want and desire, like your gentleman. He just wants 3 days worth of pain relief.
Oh, I'm so happy to get it.
A lot of good stuff.
Yeah.
That's the mall. That's going here, going there, going everywhere. There are, unfortunately, some people don't quite achieve that, and that's what they really wanted. Now they get pain relief. I mean, don't get me wrong, but it's not it's not up to what their expectations are.
And so is that where you come in? Because you said you get 90% responses. Is it 1 out of 10 that the matrix won't work for them? Are you saying?
Yeah, I really do think it. I actually I've to soften it so it's a little easier. I'd say 11% of people will not respond at all. Dennis, I got to tell you, when I'm talking to people, I really see almost nobody that gets nothing. I mean, do you ever see anybody that gets absolutely nothing?
I've actually I can recall 2 patients. Now, I let them say what they're going to. If they want to say that they got nothing, then I'm going to have to go with them. They're the ones that know.
Sure.
But I'll tell you what, in the course of these 8 years, it's happened just a few times.
That's exactly.
So, I have to always agree with a patient who says, this is what I experienced. They ought to know themselves best. I could go back and say, why? Maybe we didn't place those suction cups right. Maybe, and I wonder, why do those 3? And truly, because we worked a considerable amount of time on 2 of the 3. One that just was 1 and out. Okay, he just said, no, I'm not doing this anymore.
Right.
But, boy, that's a small number compared to the hundreds and hundreds and hundreds of people that utilize the matrix in this office, and I can see utilize it in yours. With that kind of similar results, what a device that somebody went and invented back in the 1980s, and yet you can't find the device. You're one of the few in your area. It's not the only one. I find that from Peter. So am I, and I'm in a pretty big place here. A lot of pain clinics didn't make it into those pain clinics. We got the residency programs in pain. The block boys have not come to appreciate the use of matrix, and evidently their instructors are just still not been led right down that road yet.
Exactly. And it's interesting too because I don't know if we're you of the age when they used to have the iontophoresis. That was
yes. Yes.
Remember that? You had the little battery operated device.
Yep.
And you place some lidocaine in there, and then you turn it on, and the anode pushed it in because the lidocaine molecule was positive, and the hydrochloride was associated with negative, so they separated and you pushed. Well, even the block guys that use the matrix, I swear to God, if you give a block with if you actually put medication, place medication under the skin, you can push it in with utilizing the matrix. It is such a diverse device.
Well, I'm just really so sold on this. I was happy to do the show. I looked at my own schedule. My radio, I've been doing a radio show for years. I mean, 10 years plus. And so for 8 of those 10 years, I had the matrix in my office, and I never quite ever got to discussing it in the way I've done these last 2 days. And I'm so thankful that you were able to come and share with me as a colleague your experience, which we're really so right on and similar to what we see, that anybody using this device countrywide has got to be able to deliver similar results. The machine is sort of infallible, right? Even the rookie using the machine versus the guy that's 6 years, 8 years using the machine, the results still turn out to be as accurate for the rookie as they do for the pro.
Absolutely.
Well,
and I'm learning the machine every year. I learn the machine is more diverse. There's more things I can do with it that I never even thought of.
Well, I'm so happy that you came aboard with us today, and to be able to consider you a colleague, and really in the backyard. Art, we're going to cross paths. I'm going to come visit you. You're going to come visit me or something, because I absolutely want to see what you do on right there on the job, and hopefully be able to share with me, and I'll be happy to share with you some of those insights as to the diagnoses. You know, we didn't even talk about that because it wasn't necessary. We're talking about pain relief.
Right.
But I'd really like to get into it sometime with you in terms of diagnoses. And maybe we can bring you back on the show, Frank. What do you think?
Love to have it. Thank you very much for having me, Doc.
All right, this is going up in the archives about 15 minutes from now. You can listen to it again. I'll cherish it until we meet, Frank. Ladies and gentlemen, this is Dr. Dennis Courtney with Dr. Frank Kousaie saying so long for an impact on your health. Oh, man, it was a great show. It's going to be on my platform.